All right, I think we're gonna get started here. We're closing the door up. Looks like we've got a good number of people here in the room. Welcome, everyone. Thank you so much. So as the Associate Director for the Robert J. Havey Institute for Global Health, I just wanted to open our keynote session for today. Thank you guys so much for coming to Global Health Day and participating in the poster session. And I think we're in for a really excellent talk today from one of my colleagues and friends, Dr. Satish Gopal. This is a shared center. So as I think most of you know, we have a cancer center here, the Robert H. Lurie Comprehensive Cancer Center. And so it being a shared center with our Center for Global Oncology, I wanted to start off by inviting up the Deputy Director, which is Dr. Maha Hussain, who's going to come up and make a few comments first. And then our Center Director, Lifang Hu, will introduce our speaker. So Maha.
Thank you. So actually, thank you for the welcome, but I haven't done anything, so it's okay. No, but it really is a pleasure to be here. And I'm delighted that we're having all this in person. Just putting some comments together, and I'm going to have to read them for you just because there's a lot of accomplishment that the center has done that there is no way that I can remember all of that in my mind. So just to be clear. So it is really absolutely my delight and pleasure to welcome you all for the Global Health Day keynote lecture today. This is going to be by Dr. Satish Gopal, who is the director of the NIH National Cancer Institute Center for Global Health. And I am hoping that the next time this happens, that we can have him be in person here with us, hopefully in summertime, beautiful Chicago. That would be the best time. Before we begin, I would like to make some comments about the work that has been done by the Global Oncology, which resides both, as was pointed out, in both the Cancer Center and the Havey Institute for Global Health. The Center for Global Health, led by Dr. Lifang Hu, which oversees the numerous research projects in low and middle income countries, in particular in West African region. And we were just chatting here. Where I grew up in the Middle East, there are certain illnesses and diseases that literally till today are a real issue. And so clearly having these kinds of efforts and educating and passing on best practices and things are very critical. So the Northwestern University West Africa U.S. Cancer Prevention and Control Program basically focuses on the discovery and implementation of new and existing evidence-based screening, diagnostics, and therapeutic tools for the prevention and control of infections associated cancer in West Africa. Now, leveraging decade-long successful partnership with governments, public health, and medical science leaders, and supported by funding from the U.S. National Cancer Institute and the African Organization for Research and Training in Cancer. Northwestern University has launched numerous research training programs and research initiatives with major medical universities in two of the largest West African countries, specifically Nigeria and Mali. And each has a very diverse ethnically, socio-cultural background and context. There are four programs. These programs cover four major areas. One of them is a training program for early career West African scientists to build capacity and conduct cancer research relevant to the region. The second one is training programs for West African scientists in methods and principles to contextually adapt and implement both new and existing evidence-based cancer screening and early detection tools. The third one is research projects to develop cost-appropriate and contextually feasible cancer screening and early diagnostic tools for West Africa. The fourth one is implementation science project to assess the needs and the barriers to adapt and implement both the new and existing, basically evidence-based cancer screening and early detection programs. Now, in combination, these initiatives and projects are building sustainable research and training capacity in multiple disciplines relevant to infection-associated cancer research, thereby empowering Malayan, Nigerian, and other West African science leaders. And I would say a lot of what is implemented in these regions, there's lessons to be learned, and certainly that can be then passed on to other parts. I mean, the rest of the universe is not as perfect as we think it is. There's a lot of other countries that have issues there. Now, the center now has multiple grants, and I'm going to list a few of them. An NCI U54, led by Dr. Ho and Dr. Robert Murphy, the director of the Global Health Institute, to study HIV malignancies, an R01 to study the epigenetics of oral cancers, and a U01 to conduct implementation science for cervical cancer prevention. There are 2 ongoing D43 training programs or grants, and including one funded by the NCI, and as well as a K43 and an R21 project. I'd also like to mention one particular initiative, which is that of the capacity building for oncologists and surgeons in Ukraine. And we know this is a country that is really suffering heavily at this point. This was a donor-funded project of about $100,000 for years 22 to 24. This project will bring in young oncologists and surgeons from regions of Ukraine to Northwestern University for observerships to address key gaps in screening, assessment, treatment, and follow-up care. We are for sure absolutely proud of the work that is being done through the Center for Global Health and Global Oncology, and hope you will learn more by going to the website, and I'm sure Lifang will share that. I would now like to invite Dr. Lifang Ho to introduce our keynote speaker. Dr. Lifang Ho is the director of the Center for Global Oncology.
Thank you, Marha, very much for your very nice introduction of the accomplishment of our center. And I also hope everyone has enjoyed our post session. So now I'm very pleased to introduce our today's keynote speaker, Dr. Gopal. So when I was going through Dr. Gopal's CV, I was speechless because I can't even express. I even shared with Rob how impressed I am. So Dr. Gopal has been the director of the Center for Global Health at NCI since 2020. In this role, he oversees the development of initiatives and collaborations with other NCI divisions, NCI designated cancer centers that including ours, and also the countries to support cancer research and cancer research networks, promote cancer control planning, and build capacity in low and middle income countries. Before coming to NCI, Dr. Gopal was the Center Cancer Program Director for the University of North Carolina, Project Malawi, in collaboration with the Malawi Ministry of Health. And this part, the part I'm going to read, will really impress you. Dr. Gopal completed his Master of Public Health in 2000 at UNC and earned his medical degree from the Duke University School of Medicine in 2001. He then completed the training in internal medicine and pediatrics. I don't know how he did it at the University of Michigan, and lived and worked in Tanzania from 2007 to 2009. Then he returned to the United States to pursuing medical oncology and infectious disease training at the UNC. You know, this really impressed me because how impressive, how comprehensive his training is. And no wonder, you know, he's leading the NCI Global Health. Yeah, so I was telling Rob, wow, you know, I can't tell him how much I was impressed. After this, he lived with his family. He brought his family actually during his living in Malawi. He lived with his family in Malawi. We, as NCI U54 network visited Malawi and visited his lab and what he has developed, the cancer center, Malawi Cancer Center. So he lived in Malawi from 2012 to 2019. When he was the only certified medical oncologist in a country of 18 million people and treated public sector cancer patients at the National Teaching Hospital in the capital alongside his Malawi colleagues. This is very impressive and dedicated. I cannot imagine, if I can do really, a small portion of this, what he has done. Okay, as an extramural investigator, before he joins NCI, his NIH-funded research program focused on epidemiology, clinical, and the translational study of lymphoma and other HIV-associated malignancies in Africa. He has co-authored more than 90 publications and has successfully mentored many US and Africa cancer junior faculties. Dr. Gopal, thank you very much for agreeing to join us today, and thank you. Please take it over. Thank you.
Great. Well, thanks so much, Yvonne and Chad and Rob for inviting me. I'm really glad to be here. Sorry I couldn't be there in person as I had hoped to, but had some family commitments arise that kept me from traveling. I also sound terrible today, and I want to apologize for that. We've had, like many of you probably, we've had respiratory viruses running through our house. I don't feel that bad, but I've progressively sounded more and more terrible over the course of the day. So hopefully most of this will be intelligible. If it isn't, I'll resort to some interpretive dance or something to fill in the time. But again, want to appreciate the invitation and all of your interest in the work that we're doing at the Center for Global Health, and really look forward to visiting sometime soon in person. So I'm going to pull up slides and we'll assume that this is all working, but please do let me know if it isn't. So I titled my talk "Toward Ending Cancer as We Know It Everywhere" at the NCI Center for Global Health. As some of you will know, "Ending Cancer as We Know It" is the tagline that is now associated with the President's Reignited Cancer Moonshot, which I'll allude to a little bit later. And certainly we believe at the center and at our institute that we can only end cancer as we know it if we do this everywhere. And I'll talk a little bit about why we must do that, and then also some of the things that we're trying to do at the NCI to address that, and then hopefully leave plenty of time for a rich discussion at the end. So since this is a broad global health audience, many of you are familiar, but I thought it would be worthwhile briefly surveying why cancer is such an important global health problem. So first, cancer deaths are increasing globally, and 69% of these will occur in low and middle income countries by 2040. I'll elaborate on the next two slides, but this is actually even without considering COVID and based solely on demographic changes. So these are data from our colleagues at the International Agency for Research on Cancer, or IARC. They keep the world's cancer statistics through a program called GlobalCan, which many of you are familiar with. And what you'll see here is that the majority of the world's cancer occurs in low and middle income countries. Shown in the open circles at the bottom are 2020 deaths from cancer, and in the solid circles are 2040 deaths from cancer that are projected. And what you'll also note is that the largest proportional increases are occurring in the lowest income countries, which will see a near doubling in cancer deaths between 2020 and 2040. Obviously, in settings where health systems are already vastly overstretched with many competing health needs. Just to put this in perspective, this is approximately 27,000 registered global cancer deaths per day in 2020, as compared with data that I just pulled down today from the Institute for Health Metrics and Evaluation at the University of Washington, approximately 2,000 reported global COVID deaths per day currently. So this is not to suggest that cancer is more important than COVID. Arguably, cancer control will be very difficult unless COVID is well controlled globally. But I do like to emphasize that cancer does not tend to attract the urgency, sense of urgency, public attention, political panic and anxiety that COVID, that infectious pandemics do. And this is a very large fire, but it has developed slowly over weeks and years and decades, but really requires us to focus on this with the same level of urgency that we focus on COVID. When GloboCan projects forward to 2040, they take current age standardized incidence and mortality rates and apply them to demographically changing world populations, that is, aging and growing populations, particularly in low and middle income countries. But they assume that the underlying rates that are present today will stay the same. This is not true. So that's shown here in this global burden of disease study, where you can see the age standardized incidence rates by social development index category of countries, and in blue, and the age standardized mortality rate by social development index rank category for countries shown in orange. And what you'll note is that there's a discordance in the highest developed countries. That is, you can often develop cancer without dying from cancer, but these are much more closely matched in the lowest development index countries, where it is much harder to have cancer and survive cancer, leading to an incidence and mortality that is essentially the same. For reference, the US cancer mortality rate peaked in the US in 1991 at 215 per 100,000. So that's approximately here on the y-axis, and has declined in the most recent data that we have from 2019 to 146 per 100,000. This is a decline of approximately 32% over 28 years, or an annualized rate of change of approximately 1.1% per year. So now looking at global burden of disease trends over the last decade between 2010 and 2019, with respect to the annualized rate of change, what you'll see immediately is that incidence and mortality rates are declining. That is, there's a net negative annualized rate of change, whereas the opposite is occurring in the lowest developed countries, where there is a net positive in the annualized rate of change between 2010 and 2019. So if you take anticipated aging and growth of populations, and then also apply the fact that cancer mortality rates are declining in most high-income countries, just as they have in the US in recent decades, but are increasing in many LMICs, I think that it is likely that LMICs will bear an even higher proportion of future cancer burden than is currently projected in GloboCan, where current age standardized rates are assumed to be stable over time. This is even more concerning if one considers potential COVID effects. And I think we've learned a lot about the effects that COVID has had on cancer control in high-income countries. Much of the data that is required to inform sophisticated modeling efforts around these impacts in low and middle income countries is not available simply. Some of the best data that I am aware of is from Chile. So this is a simulation model from Chile, which was a good fit to available public health sector data. But Chile is an upper middle income country with a very strong public health infrastructure. And what they have observed is across these 5 most common cancer sites, a surge in new cases occurring after the pandemic. This is accompanied by worse stage distribution and survival, that is, fewer stage 1 and 2 cancers and more stage 3 and 4 cancers, which has led to a decrement in overall 5-year survival during this period due to COVID. And what this translates to is the surge in new cases, together with worse stage distribution and survival, has led to 3,500 excess cancer deaths in Chile from 2022 to 2030. And this is a conservative estimate. This is assuming very time-limited effects of COVID, which I think are likely not true, and not considering any effects on treatment delays or quality reduction. So again, I think the current data is alarming in and of itself, but much more so if we consider the fact that rates are differentially changing around the world, and COVID is likely having major effects that are difficult to fully capture in low and middle income countries particularly. So that's cases and deaths. Even beyond that, I think are just starting to wrestle with the broader societal effects of cancer at a global scale. This is some work that was very important around HIV for catalyzing the kind of political development, donor interest in HIV as not just a health problem, but an economic, societal, and development problem. And I think that kind of work around cancer is just beginning. But just for example, there's immense human suffering that is associated with the cancer cases and deaths that I just described. This is a study published a couple of years ago where they looked across country income category, what were the principal causes of deaths with serious health-related suffering, and how were these anticipated to change between 2016 and 2060. And what you'll see is that cancer causes 1/3 of all deaths with serious health-related suffering by 2060. This is 16 million people, with major increases occurring in the lowest income countries. So this is obviously reflecting what I showed you a couple of slides ago. That is, burden is massively increasing in these countries. And of course, cancer deaths are typically associated with significant health-related suffering. So I think we're just coming to grips with the suffering that's associated. Similarly, with the economic loss, many of you will be familiar with a fairly vast body of literature now from the US describing the remarkable degree of time and financial toxicity that patients assume in the course of seeking cancer care. Again, I would argue that we have just begun to scratch the surface with respect to these problems in low and middle income countries. Some of the best and really pioneering work that I'm aware of is by Nirmala Bhupati and colleagues in Malaysia. Malaysia, again, is an upper middle income country with a very strong public health infrastructure and universal health care. But even there are major rates of financial catastrophe and medical impoverishment 1 year after cancer diagnosis in Malaysia. So financial catastrophe, as defined as out-of-pocket expenditures more than 30% of annual household income, occurred in approximately half of patients 1 year after their cancer diagnosis in Malaysia. And particularly if they sought care in a private facility, this rate was even higher. Medical impoverishment, defined as a household that was above the national poverty line, moving below the national poverty line, that occurred in more than 1/3 of families 1 year after cancer diagnosis. So again, I think there's a lot more work to do, but I think what we know is really worrisome. And this is the kind of work that we're really interested in continuing to reckon with the broader societal effects. These effects are multi-generational. And again, there was so much work to understand the effects that that maternal orphans, that losing young women to HIV would have on societies in sub-Saharan Africa, that really helped to catalyze major political momentum around addressing HIV as a global priority. Again, I would argue we've just begun to scratch the surface. There's very recent work in this area looking at the same concept of maternal orphanhood in the context of cancer. And I think what these authors, and this is work that some of my colleagues at the Center for Global Health have been involved with, but led from our colleagues at IARC. In 2020, there were 1 million new and approximately 7 million total maternal orphans from female cancer deaths worldwide in 2020. And you can see that these are primarily concentrated in sub-Saharan Africa, where because a large number of young women die of cervical and breast cancer. For those of us who practice medical oncology in the US, it's relatively uncommon to have a young mother die of cancer and leave behind children. And it's deeply affecting when this occurs, but thankfully this occurs perhaps a few times in one's career for most practicing medical oncologists. This is a daily occurrence when you're practicing medical oncology in sub-Saharan Africa. And again, I think really speaks to the broader multi-generational effects that a cancer diagnosis will have on societies, because these are all relatively young children who will essentially spend the rest of their childhood without a mother because of a cancer diagnosis. So that's all just to briefly survey the importance of cancer as a global health problem for the purposes of a broad global health audience. What I'd like to talk a little bit now is how good have we been as a cancer research community at addressing this? And I would argue that there have been very important successes, but also some real failures and inequities. And because so much of my own work is focused on clinical and translational studies of lymphoid malignancies in Africa, I often use Burkitt lymphoma as a familiar and convenient example. So Burkitt lymphoma was discovered when Ugandan children presented to Dennis Burkitt, an Irish surgeon in Kampala, with this unusual craniofacial tumor, which he initially thought was a sarcoma. So he then sent this tumor to specimens from these children to colleagues, pathologist colleagues in London, who identified this as a lymphoid malignancy that we now know as Burkitt lymphoma. So a new human tumor was discovered. These colleagues then looked at these tumor specimens under an electron microscope and noticed viral bodies included in the tumor specimens, and which we now know as Epstein-Barr virus. So first discovery of a new human tumor, first discovery of a new human oncogenic virus. This then led to a lot of work trying to understand how to best treat this tumor and to the discovery of modern principles of multi-agent chemotherapy. This included John Ziegler from the pediatric oncology branch at the NCI going to live and work in Uganda and learn from Ugandan collaborators how they were treating this tumor. He then brought this experience, ironically, back to the NCI and tried to treat patients in the US in the same way. And the fact that he was able to achieve similar outcomes to what they were achieving in Uganda was felt to be so important that this was published in the New England Journal of Medicine in 1977. This subsequently led to Ricardo Della Fabra, while he was at the NCI, characterizing the typical 814 c-MYC translocation. So a new human tumor, a new human oncogenic virus, principles of modern chemotherapy, multi-agent chemotherapy, a new human oncogene. More recently, in Lou Stout's lab, there's been comprehensive molecular profiling really demonstrating that the tumor biology for Burkitt lymphoma differs substantially based on whether or not EBV is present. And all of this biologic insight and epidemiologic insight over many years has led to progressive therapeutic optimization through a whole variety of strategies, such that patients with Burkitt lymphoma, children, adolescents, and adults participating in US or other high-income country clinical trials do amazingly well. We actually think now in the NCI lymphoid malignancies branch that it's impossible to do a relapse refractory Burkitt study because everyone does too well after standard therapy. The thing that I always point out to my NCI colleagues is that I think what we've failed to do is translate a broadly deployable solution back to the very children who helped initiate these decades of discovery. And I say that not just to say it, but based on my own lived experience in Malawi, where we largely saw children presenting just as they did for Dennis Burkitt in the 1950s, who did just about as well as was initially described in the 1950s and 1960s. And I think this is a moral failure, just to be clear, but I also think it's a scientific failure because I think there's such a natural opportunity now to take these decades of discovery and think about how we translate something back again to the very communities who helped initiate these decades of discovery. And a lot of my own work has focused on this final arrow. And I'm not going to talk about any of that today, but we'll talk a little bit about some of the things that we're doing at the NCI to try to overcome this last reaching some of these communities. So just as another example of cancer research, I believe still having failed to meet the challenge of increased cancer burden in LMICs, this is a really nice paper analyzing all of the English language reports of phase 3 studies testing any cancer-directed therapies published between 2014 and 2017. So there were nearly 700 cancer RCTs in total, nearly all of them in high-income countries, 51 in there were 8% overall that were in low and middle income countries. Most of these were in upper middle income countries, especially China. A few of them were in low middle income countries, particularly India. There were no studies published that were in a low income country. And what results, I mean, those of you who are even early stage researchers will know that a biased sample leads to biased results. And so our body of accumulated cancer RCTs is a biased sample, which is poorly matched to global cancer burden. So this is showing the top 10 cancers by mortality worldwide and the top 10 cancers by RCT. And what you'll notice is that a few very common cancers worldwide are very poorly represented in the RCT literature. So, and particularly cancers that occur with high frequency in LMICs. So liver cancer, cervical cancer, for example. Surprisingly, even though they were only 8% of all of the randomized controlled trials, the RCTs conducted in LMICs were more often identifying effective therapies with larger effect sizes. So they met their statistically significant, they met statistical significance for their primary endpoint in approximately 2/3 of LMIC RCTs versus slightly less than half of high income RCTs. And the hazard ratio was the effect size as judged by the hazard ratio was also larger typically for LMIC RCTs. And then finally, despite being a better match for global cancer burden, despite perhaps being more thoughtful in their design such that they identify more frequently effective therapies with larger effect sizes, there's bias against these studies. Most likely, they tend to be published in lower impact oncology RCTs. And that's true whether or not this study was ultimately positive. So I think there's a lot more we can do as a cancer research community to really meaningfully address cancer as a global problem. So I'm going to shift now and talk a little bit about what we're trying to do at the NCI before we open it up for hopefully some really interesting dialogue following this. So this is the NCI, the largest funder of cancer research in the world. I always like to just use this slide to illustrate that we're a big complex organization with different parts of the NCI focused on different aspects of cancer research. We've been thrilled in recent weeks to welcome Dr. Monica Bertagnoli as our new NCI director. I've had the chance to talk extensively with her about some of our global health programs. And she, I think, will be an amazing leader for the NCI and a strong champion for much of what we're trying to accomplish within our center. But we really are the part of the NCI that has a primary focus on applied research and control in LMICs from a disease agnostic and transdisciplinary viewpoint. So we try to collaborate all across the Institute together with many other external partners within and outside the NIH to advance our agenda, in addition to supporting global health engagement and coordination for the Institute more broadly. I also always like to point out as well that the NCI has always been engaged in global health research. And for those of you who enjoy medical history, we've reviewed some of that really fascinating global health history of the NCI in a recent paper. But these are just some examples. So this is geographic pathology mapping in the 1960s done by investigators at the NCI to demonstrate the very high frequency of certain tumors in some parts of the world, which of course has led to many sophisticated epidemiologic and etiologic studies to try to understand some of these differences. This is a study in the Jian province of China in the 1980s, testing dietary interventions to reduce cancer risk, which was the first time that dietary interventions was demonstrated to actually reduce cancer risk in some instances. And so we definitely feel that this is an important part of what we do with major scientific benefits, even apart from the moral obligation to address the immense human suffering that occurs due to cancer worldwide. But even as a research institute, we know that we can effectively study rare cancers only through global collaboration, for which single country efforts will have limits. We know that we can foster innovation and efficiency, less encumbrance by policy and practice conventions in any given country, increase the contextual understanding for addressing cancer in diverse populations and communities in the US, and also validate and extend discoveries from the US to other populations, contexts, and health systems. So we've been thinking a lot about where we are now. And last year, we actually celebrated the 10th anniversary of the Center for Global Health, which was established by Harold Varmus when he was the NCI director. He's continued to be an amazing mentor and source of wisdom for me. And we've had the chance to talk about our direction multiple times and have revisited, used the 10th anniversary as an opportunity to revisit kind of some of what we had accomplished and some of where we'd like to go. We have a publicly available strategic plan, which is at our website. Ned Sharpless and I wrote a commentary in JAMA to highlight some of the main themes in our strategic plan going forward. And this was really hearkening back to a piece that Harold Varmus and Ted Trimble wrote in 2011 when they first established the center. So they established the center, and at that time we're seeking to integrate cancer into global health, given that cancer was not frequently mentioned in broader global health meetings. I think our charge is quite different. In 2021, we're no longer trying to establish a center. We're trying to evolve our center to meet the needs of the future that I tried to describe in the first few slides. And I think it's also now important, no longer sufficient to integrate cancer into global health, we really need to prioritize global cancer. And again, I tried to provide some data illustrating that, and I'm really pleased about all of the work that you all are doing in Northwestern in this regard. I also want to just mention the Reignited Cancer Moonshot. So many of you will have heard about this. This is something that the president announced earlier this year in September. And there are two national goals that have been articulated. One is working together over the next 25 years to reduce the age-adjusted death rate from cancer by at least 50%. And I showed you already that we've accomplished the reduction of 32% over the last 28 years. And so this would be a significant acceleration of the progress that we've seen in recent decades. And then the second goal is to improve the experience of people and their families living with and surviving cancer. And it's really fun now to participate in conversations within the NCI about how we, as the largest funder of cancer research in the world, can help make this a reality together with all of government, all of society, stakeholders that are participating in this larger effort. In 2016, when President Barack Obama announced the original moonshot in his State of the Union, as Lee Fong mentioned, I was living and working in Malawi as a medical oncologist and NCI supported physician scientist, and actually thought a lot at the time about what a moonshot might mean for our patients in Malawi, and actually wrote about this. So it's really fun now to be thinking about now at the NCI, how we make a moonshot effort really affect the lives of people that I interacted with and took care of in Malawi. And I expect that there'll be some important global health opportunities that emerge through this Reignited Moonshot phase, although this is many of those plans and priorities are very much still in development, and we're contributing quite actively. So this is just to highlight some of the main features of our strategic plan. And I'll just try to, rather than being encyclopedic, I'll just try to provide some brief illustrations of things that we're doing in several of these domains. But our goals are focused on supporting research training, supporting dissemination efforts that facilitate science-based global cancer control and policies and practice, and then partnerships. So we enjoy partnering with all of you at the NCI designated cancer centers, as well as many other partners around achieving global cancer research and control. And thematically, our research efforts are shown here. They're really focused on accelerating technology development for global cancer control, accelerating global cancer implementation science, understanding and addressing global cancer health disparities, increasing support for cancer clinical trials, and then continuing to increase our understanding of cancer etiology and biology through global collaboration. And I'll just talk briefly about each of these areas. First, I want to show you the NCI extramural global portfolio overall and over time. We just completed fiscal year 22. So the last data that we've analyzed is through fiscal year 21. So in 21, approximately 13.5% of NCI extramural awards included an international component. Most of these are foreign component awards. That is an award to a US institution that then has collaborating sites. Internationally, a much smaller proportion are direct international awards. You can see here that there's good representation in general across the cancer control continuum and across cancer sites. And this proportion has increased steadily over time, roughly contemporaneous with the existence of a dedicated Center for Global Health at the NCI. So in 2011, this proportion was 10.1% and has increased again in the most recent year that we've analyzed to 13.5%, although the proportion of direct international awards to international institutions has remained flat and quite small. So we don't take all of the credit for this at the center, but I think these are related phenomena. That is, I think the NCI signaling that it had wanted to escalate its engagement in global cancer control by creating a dedicated center, in addition to the programs that we have advanced within the center, created broader understanding and awareness within the cancer research community that this was something that the NCI was interested in. And I think you've seen a response from the investigator community reflecting that. So the NCI extramural global portfolio is distributed all around the world, although some regions are better represented than others. And there is a clear income gradient, I think similar to what you see for cancer research overall. That is, much of this international work is US institutions collaborating with other high income country institutions. And as you proceed down the World Bank categorization of countries, there are fewer and fewer grants that involve those countries. Looking at, so this is showing the individual countries that are have the highest representation in the NCI extramural portfolio. And this is now focusing on the LMICs, which is actually quite similar to the NIH portfolio overall. So I just want to touch on some examples of the kind of work that we're supporting at the NCI that's aligned with these goals and thematic areas, just to illustrate and the kind of work that we're really interested in supporting a lot more of. So one is this technology development. We know that current tools developed in the US often don't work that well in LMICs, and so have over many years had a program called the Affordable Cancer Technologies Program that is really designed to support late stage validation and testing in LMICs of new global cancer control technologies. And this is just an example of one outcome from that program, which is the validation of thermal ablation devices for cervical cancer pretreatment. So as you will know, the WHO is trying to eliminate cervical cancer worldwide, which rests on three fundamental pillars: 90% vaccination of school-age girls, 70% of women being screened between the ages of 35 and 45, and 90% of those with pre-cancer or cancer getting effective treatment. And treatment of precancer previously relied on liquid nitrogen cryotherapy, which is a completely unworkable solution, particularly in rural clinics in many parts of the world. Even for groups that have a lot of resources and logistical know-how, maintaining a continuous supply of these bulky, pressurized, gaseous cylinders is basically impossible. And so we think it's been a major step forward to support the development of these handheld battery-powered thermal ablation devices as an alternative for treatment of cervical precancer. And grantees from this program provided their data to the WHO, which was almost immediately taken up into WHO guidelines because this was in such need of a new solution. This program continues. We're supporting a lot of cool artificial intelligence applications now, for example, to automate steps of radiotherapy planning in South Africa, in addition to urinary biomarkers for colorectal cancer screening in Nigeria. So there's a lot of really interesting and cool work that, of course, will have relevance for reaching populations even within the United States. We're also very interested in continuing to support work that's focused on global cancer health disparities. This is just one example, the ABCDO study led by Val McCormack at IARC, which is attempted to document breast cancer survival differences and contributing factors across African contexts. So for example, even within Namibia, you see a given country, you see much of the same racial gradient that we observe in the US. That is, white women do better than mixed race women, do better than Black women. And these authors, more than that, have sought to identify what are the reasons for these survival gaps. And you can see that much of the survival gap is made up through downstaging, improved treatment, and reduced social inequalities. And so we think that doing this kind of comparative work to understand why certain populations may be disadvantaged in a consistent way all around the world will be very informative to some of our efforts to address disparities even within the United States. The other thing to note is that sometimes LMICs, despite having fewer resources, have less disparity. That is, even though the point estimate is lower, the confidence interval is narrower, and that too may be an opportunity for us to learn how to effectively prioritize and get effective interventions out into communities in a much more equitable way. We're very interested in increasing support for cancer clinical trials in low and middle income countries. The NCI is a major supporter of cancer clinical trials worldwide, but the portfolio in LMIC specifically is fairly limited. And we've been doing a lot of work this year to try to analyze that portfolio and think about what are the real opportunities for us to contribute here. One really important example of work that the NCI has supported in LMICs around this topic is the AIDS Malignancy Consortium. So, for example, I showed you already how poorly represented LMICs were in published RCTs during 2014 to 2017. This is now a large randomized phase 3 trial conducted by the AMC in Africa, demonstrating that paclitaxel is a better therapy for advanced HIV-associated KS than bleomycin and Christian or etoposide, a therapy that was previously thought to be too expensive, too challenging to administer, too intensive for local health systems, but really now is established as the new standard of care. And this has been rapidly taken up into the NCCN guidelines. You all will be familiar likely that the NCCN has an effort to standardize guidelines and provide context-specific guidelines for sub-Saharan Africa, and this is a really important effort. However, guidelines are made powerful not only by the guideline development process, but I would argue by the evidence that undergirds them. And so taking guidelines that are largely formulated from evidence from the US and simply crossing out the things that we think are too infeasible or too expensive for Africa, I think we can do better than that. And that's not the ideal. So ultimately, we need trials that are really informing practice and guidelines in Africa. And we're thinking a lot about how we might support more of this type of work. We're also, as I think, as Li Fang mentioned, really interested in global cancer implementation science. That is, this is a relatively new field. The original phase of the moonshot actually supported a lot of investment in domestic implementation science networks and consortia. And we're now trying to apply a lot of those same methods and approaches to address cancer in LMICs, because we know that even if we have the tools and technologies and therapies, we have to demonstrate that we can get them out into populations with high fidelity, uptake, sustainability, et cetera. And so this is just an example of some work done by my CGH colleague and our deputy director, Patty Gravitt, kind of aligned with a lot of the things that we're trying to support going forward, which is that kind of understanding with women the trade-offs in different cervical cancer screening algorithms, and appreciating that there's really some emotional cycling that occurs as women proceed through this cascade of steps and interventions, but are ultimately very satisfied, particularly if this cascade can be completed in a very time and effort efficient manner, such that they're not spending enormous amounts of time, particularly in these emotional naders, or worse yet, left there indefinitely without completion of the cascade. We're really interested in training and career development, as I mentioned. This includes new programs at the NCI to support institutional training partnerships between LMIC institutions and NCI designated cancer centers, like the program that you all are leading now with your colleagues in Mali. We know that as trainees proceed through these institutional training programs, that they will need their own early career development support. And so we work very closely with the Fogarty International Center to co-fund applications for their career development awards where there's a strong cancer focus. And then finally, at a later stage, we have programs that support collaborations between more mature scientists and LMICs, often with the NCI intramural program. And so this is just an example of a recent collaboration that we supported at the Center for Global Health between scientists in India working with our NCI intramural scientists to develop new endogenous CAR T manufacturing capacity within India for the first time, which is tremendously exciting. I mentioned that we really try to disseminate and partner for science-based global cancer control. I've just illustrated here a few of the things that we do in this domain. So we convene some key scientific meetings for global cancer research and control. I'll talk specifically about this meeting on the next slide. We have tried to create a new seminar series at the NCI to invite global thought leaders to educate the NCI community. For example, I spoke already about Nirmala Bhupati's work around financial toxicity in Malaysia. Earlier this year, she came and spoke to us at the NCI about that work. These are open seminars that are available to anyone who wants to participate anywhere in the world. We also support a program called the International Cancer Control Partnership with the Union for International Cancer Control, which is a multi-stakeholder coalition that, as countries are ready to develop a national cancer control, they apply to be part of the ICCP and then get technical support as they're developing, implementing, and evaluating their national cancer control plans. And what is emerging now is a really rich community of practice where countries that are at various stages of development, implementation, evaluation are really learning a lot from each other in a way that we even can't provide at the NCI. And so that's become a really rich forum for cancer control planning at a national level. I just wanted to mention this upcoming meeting, which is our kind of flagship meeting. So this is the annual Symposium on Global Cancer Research. We believe this to be one of the largest and longest running scientific meetings dedicated to cancer research and control in LMICs. During COVID, we reconceptualized this as a fully virtual, free, highly engaged virtual meeting that hopefully will allow anyone working in cancer research and control anywhere in the world to feel part of the cancer research enterprise and to participate. In particular, individuals who may often not be able to come to AACR or ASCO or ASPO or aortic for time and expense issues, to really complement these other amazing scientific meetings that occur on the cancer research landscape. So our call for sessions and for abstracts is open. And so I'd encourage any of you who may be interested to consider submitting and or attending. Finally, I just wanted to close by saying a couple of things about global oncology at the NCI designated cancer centers. And working closely with the cancer centers is a major interest to us. We're having our National Cancer Advisory Board meeting actually on Monday, and we'll be talking about global oncology at the cancer centers. So that's a public meeting. So for those of you who are interested, I'd encourage you to tune in. But every few years, we survey what the cancer centers are doing in global oncology. And we believe this to be the most comprehensive and systematic data capture. The things that we are supporting directly as NIH are actually very easy for us to capture. What is harder is all of the things that the cancer centers are doing, even without NIH support. This is very similar to what the cancer centers do domestically, right? Where they do many things to serve their catchment area, even beyond the relatively modest core funding that the NCI provides. And global oncology activities have increased steadily in recent years at the cancer centers. So nearly all cancer centers are now doing some global oncology activity. Approximately 40% have a dedicated global oncology program. And many of those that don't have a global oncology program indicate an intent to create one within the next several years. This is a survey of cancer center directors indicating that for most cancer centers, global oncology is at least a moderate, if not a high or extremely high priority. And this is just demonstrating the range of funding sources that they're drawing on to support their global oncology activities. We're very proud at the NIH to be the major supporter. But again, this is very similar to what is occurring domestically, where we know that the cancer centers are unlocking a lot of other resources available to them to support this effort. Global oncology efforts at the cancer centers also complement the NIH supported effort in many important ways. So as a research institute, we of course primarily fund research. So with these other sources of funding, cancer centers are better able to support capacity building and clinical practice. There's better representation, for example, of cancer control, survivorship, and outcomes research in the things that the cancer centers are doing, even without NIH funding, whereas NIH funding tends to often focus on biologic and etiologic research. And then we, of course, at the Center for Global Health, given our primary focus on low and middle income countries, are really happy to see that so much of what the cancer centers are doing through other sources of support is directed towards the global South, in comparison to what I showed you with relation to the NIH extramural portfolio earlier on, which, as we mentioned, is largely focused in other high income countries. And so continuing to work with the cancer centers to increase global representation in cancer research, particularly in LMICs in the global South that have historically been underrepresented. We're grateful to be able to work with the cancer centers on this. So to conclude, I really feel that there are major opportunities for a renewed and ambitious global health strategy at NCI. We lead the applied NCI research and control efforts in LMICs to help realize these opportunities. We know that the global oncology activities at NCI designated cancer centers are key to this effort and complement NCI supported activities in many important ways. And it's only by achieving this together that I believe we can end cancer as we know it everywhere, make cancer a true global health priority, and allow all people to contribute to and benefit from cancer research. When I moved to Malawi, the patients that I saw in clinic did not feel that cancer research was for them. And I think the main thing that we accomplished during the time that I was there was demonstrating that they could contribute meaningfully to cancer research and also benefit from cancer research. And that same experience, I think, is what we're trying to accomplish to a large degree at the Center for Global Health now. So I'll end there. This is our website. If Twitter survives, this is our Twitter handle as well, and my Twitter handle. So look forward to your questions and comments. Again, hopefully visiting in person sometime soon. So thanks very much for the opportunity.
Okay, we do have a little bit of time for Q&A and a couple of questions. Are there any questions from the group in the room?
I can ask.
Oh, okay. Yeah.
Yeah. Thank you so much, Satish. This was like.
Actually, why don't you use that so he can hear you?
Yes, this was lovely, actually. So one of the questions that I have is, there are issues that run in different parts of the world, including our own country. So having worked in inner city Detroit, literally, we took care of the auto executives and we took care of the homeless, inner city person. And funding and insurance and healthcare is critical. So now you translate that into the rest of the world, especially in countries in Asia and Africa, where you have poverty, you have dictatorships and things like that. So implementing a lot of these things is going to be really not easy, and figuring out how to best validate what is being said there and how to implement it is really a huge barrier. So I wonder about your thoughts, because you obviously lived in different parts of the world and understand what I'm referring to.
Yeah, no, thank you so much, Maha, for that question. There's probably a couple of points to make there. One is we know that our work in global health has relevance for underserved populations in the United States, and we're trying to make those connections much more explicitly now at the NCI. So, for example, many of the technologies that have been tested in low and middle income countries through our Affordable Cancer Technologies program have actually been brought back to the US and applied to populations in the US. And we would like to do more of that, and are thinking a lot about how to better connect global health and domestic health disparities communities, because we think there's tremendous opportunity for scientific synergy there. You're right. I mean, one of the reasons that we always feel at the NCI grateful for the strong political support that we have enjoyed over many decades, no matter which administration is in control, and that simply doesn't exist. Often, what you find in other LMIC countries is amazing groups and investigators and individuals doing remarkable work under truly heroic circumstances, but don't have the level of political support that they need. We are trying to make that argument. This is one of the advantages of being a US government agency and this Reignited Cancer Moonshot. So, which is intended to be a US government, kind of all of government, all of society approach, and which we believe will have likely a strong global health component. But for example, the president is, you may know, in a couple of weeks is having a US Africa Leader Summit we have been supporting the development of some possible cancer specific side events. And the goal there would be, I think, to achieve some of what you described, which is try to create the political visibility and commitment that would be similar. And one of the things that we have sort of advocated for in pursuing these engagements is, perhaps we've articulated this clear goal, right, of trying to reduce cancer by mortality by 50% over 25 years. And it might provide an opportunity for other countries to set their own self-determined goals. That is, maybe that doesn't quite make sense for you if your cancer rates are actually increasing in recent years, but what would make sense? Maybe 50% HPV vaccination coverage for eligible school-age girls. So I think there's going to be opportunities that arise like that to create more favorable conditions, probably not everywhere in the world, but at least in more parts of the world. And we're certainly pursuing those conversations very actively.
Thank you.
The other thing to say is cancer does not feature prominently in the development agenda, and we're speaking a lot with USAID and others about that, and hope that the all of government moonshot approach will allow some greater prioritization of cancer within the broader development agenda.
The questions? Li Fang, you have one? I can bring you the mic.
Thank you so much. This is really open.
So you can hear you.
Can't shout over that.
Thanks so much, Lisa Hirschhorn, the director for the Ryan Family Center for Global Primary Care. So thanks so much for this really great talk. One of the things about reaching for equity, both geographic as well as others, is integration into primary care and sort of strengthening that as a platform, which USAID has now, under Atul Gawande, has really sort of adopted. What's your thoughts about sort of the role of NCI in that work to really continue to integrate in, so that rather than having vertical programs, we're thinking about it a little bit more holistically?
Yeah, that's such a great point. So first, in many parts of sub-Saharan Africa, a primary care infrastructure only exists for HIV infected people, right? Because that's where all of the investment has occurred. And they often have to go, maybe not monthly anymore, but at regular intervals to get their medicines refilled and a general check-in. That kind of infrastructure doesn't exist for HIV negative people. And as a result, we often see in African context a reversal of the typical disparities that we associate with HIV status in the US. That is, in the US, HIV infected individuals tend to be disenfranchised in many ways from broader society, but often in sub-Saharan African context, actually higher wealth is associated with higher likelihood of HIV in some populations because you have to have enough wealth to create the opportunities to acquire HIV, for example. But there's also a primary care infrastructure that, even if that infrastructure is currently not well equipped to manage cancer, at least there's someone seeing that patient regularly who can refer them promptly as needed. And so, for example, I worked a lot on lymphoma in Malawi, which is about 50-50 between HIV positive and negative individuals. And we routinely saw that the HIV positive individuals were referred much earlier with much shorter symptom durations. So in some ways, the having a functioning primary care infrastructure offset the kind of disadvantage of having HIV, if that makes any sense. So I think connecting with, in addition to primary care, there's obviously a strong community health worker network in sub-Saharan Africa that we often lack in the US. And I think tapping into that, we're hoping to do that effectively with some of our implementation science programming, which will have to rely on some of those existing structures for population scale delivery. And again, this is a topic that we have talked about quite a lot with USAID and hope that there'll be kind of opportunities for more meaningful collaboration around this.
Okay, and I think maybe just one last question. I think that's all we have time for, and then we'll let you rest your voice. And it's going to be from our center director, Li Feng.
Hi, Satish. Thank you very much for your outstanding speech. So my question is about, you mentioned in several areas that NCI will increase the funding in the next couple of years. One is the disparity, cancer disparity. So when it comes to cancer disparity, I think we all know it can be done at different levels, right? It can be at the community level, can be within the same country or multiple countries. So in several NCI meetings with NCI, my understanding is NCI encourage multi-country studies. So we like that idea. But then the challenge for us is the funding, the mechanism limits us, to do really sufficient if we have multi-countries. And my question is NCI considering to develop some specific mechanism to build multi-country cohorts, network, right, for us to address this, because this is a great idea if we can simultaneously including several countries. Thank you.
Yeah, we agree. So I think we're trying to think about what we would do that would be that would have the greatest impact. So I expect there will be more in this area. We have done some catalytic small things just to start stimulating some of work in this area. For example, we've done supplements to domestic health disparities, grantees to consider including international populations in their work. And those have had, I think, a tremendous response from the community. And have provided a nice foundation for us to at least test that this is a viable, this would be a viable program that we should try to conceptualize. The other thing I would say is this has also come up a lot in various international discussions. So we, at our center, we helped organize the US-UK Summit, Cancer Summit last year, which resulted from the G7 meeting last year, where President Biden and Boris Johnson wanted to have a cancer summit. One of the main topics that arose during those discussions was the opportunity to study how health disparities occur similarly and differently between the UK and US health systems, given that the health systems are very different. Often race operates very differently in different environments. We've had a lot of discussion with the EU recently. So the EU has a beating cancer plan, which is sort of aligned with our cancer moonshot. And much of the goal within that EU cancer plan is to address the marked disparities that occur across the European Union. So I think the kind of work that you're articulating has been certainly something that we're interested in, and that has been recurrently highlighted as a real scientific opportunity to do comparative studies across countries of how disparities occur and how they might be mitigated. So I expect we'll be doing more in this area and have done some catalytic testing of the waters to date.
Okay, on that note, we want to thank you again so much for coming and being our keynote speaker. This is the end of our keynote and almost the end of Global Health Day. Not quite, right? We have a little reception, and awards. So everyone, please, we can go back out into the reception lobby area where the posters were, enjoy a drink and some hospitality and Global Health Day. So thanks again so much, Dr. Gopal.
Thanks, everyone. I look forward to visiting in person, and sorry I had such a hard time talking today, but really enjoyed being
Go
here.
rest your voice.